Hello, this is Renee Clark. We're going to review some of the common HEENT disorders in primary care: head, eyes, ears, nose, and throat. Also note the oral exam, which is very important in the HEENT, and we are covering that later in this module. Today we'll be covering just those things that you commonly see in primary practice as a nurse midwife, which is the common cold, conjunctivitis, otitis media, acute sinusitis, pharyngitis, and influenza. These are also covered in all of your readings in Varney and Yunkin. First is the common cold, which you know is a virus. It is self-limiting, resolve on its own, generally within 3 to 7 days. We know that there are hundreds of viral strains that cause the common cold, and we don't expect that you memorize this, but you should be aware of them listed here in the slide. Most important is the mode of transmission, which is both important for you as a nurse midwife to prevent the common cold for yourself in clinic, especially during the winter season, and also, of course, in education for your clients. So decreasing hand to face or hand to eye contact is important, covering your mouth when you sneeze, all of those things that you know. Incubation for the cold is generally 2 to 3 days, meaning you will be passing the virus prior to feeling symptomatic. This is especially important then in education for clients who are in crowded situations, so big office buildings, poor ventilation, and crowds also we think of college-age clients. Keep them in mind, and families with young children, as I'm sure all of you are aware, especially those of you who have children of your own. And you'll notice incidence at the bottom of the slide. Incidence increases from 2 to 4 colds per adult per year to 6+ per year for parents of small children. Another reason this is important is both for prevention for you as a nurse midwife, so that you're not passing from client to client, and also for your pregnant clients, for those mamas who are multiparous and have children at home, or especially when their children are in daycare. So the most important thing to understand about common cold is transmission, incidence, incubation, and all of that is for prevention. As you can see here listed on this slide are the subjective and objective symptoms of the common cold, all of which I'm sure you're aware of. In the subjective side, you will notice that most people will feel symptomatic generally a day or two after their first contact. So after following that incubation period, it can last up to 3 days. Most common is the next day, and they will start then having the fatigue, runny nose, dry throat, etc. Generally, the common cold will progress and last no longer than 7 to 10 days. Most common is 5 to 10. Objective, we will see nasal secretions, but we should also hear clear lung sounds. So when listening, ensure that you have an understanding that if it's a common cold, it's upper URI symptoms, and you should have clear lung sounds. Lymph nodes are also usually non-palpable, and that's because this generally stays in that upper respiratory area. Differentials to be aware of are also listed here. Bacterial, be aware of what those could be. Viral, obviously we do want to rule out the Epstein-Barr virus, mono, or CMV, so be aware of what those are generally as differentials in order to rule them out and diagnose just a common cold. Make sure you're not missing anything there. Allergies generally play a huge role in the common cold in the winter for those who do suffer from them, so you might see them in tandem. Common cold, again, if you look under incubation period, so beginning in that 2 to 3 day window when they're experiencing symptoms all the way through a 10-day course of the illness, the common cold should then decrease in terms of symptoms and resolve altogether by the end. So if somebody has allergies, and here at the bottom of the slide you'll see allergic rhinitis, sometimes those symptoms will last longer. So that should remain in your differential, and your client should be educated about the total course of a common cold so that follow-up can occur if they have persistent symptoms. Know how to educate your client regarding the common cold, and then follow up, making sure that a client does follow up if she has persistent symptoms, and also if the fever exceeds 102, as that would not be normal for this cold. If there's any worsening pain in the ear, face, or chest, that's not something we'd expect with a common cold, so she should know to call back. Any cough with dyspnea is also not normal, and any progressive or persistent symptoms that we talked about before. So in general, understand a common cold, how to diagnose, how to rule out your differentials, and when to have your client follow up. Conjunctivitis. So a red eye is the most common eye concern in primary care, and as a nurse midwife you will receive calls about this, both with a list of symptoms and then also presenting patients in clinic. It's important that you understand the difference between viral, bacterial, allergen, and other causes listed here. Those not on this slide are foreign bodies and chemicals, and those are important as well, and the reason that a thorough history is warranted also always for conjunctivitis as well. You'll see under epidemiology the most common viral causes, including adenovirus, bacterial causes, and STI associated. I have STI associated listed here as these are important differential diagnoses as you consider the causes of conjunctivitis. Those STI associated should be referred to an ophthalmologist due to the high risk of vision loss. So I'll have you understand those generally in this presentation as well. This is an important list of subjective questions to ask your client in the thorough history. I'm not going to read through these as you can do that in the slide, but I will point out a couple of important considerations. Those wearing contact lenses, you should understand that bacterial is more common just because of the hygiene practices and the difficulty in cleaning those contact lenses. When discussing pink eye or any eye symptoms with wearers of contact lenses, you should encourage them to remove those lenses and wear glasses until symptoms resolve. Especially if they're being treated, those should also remain out of the eye until treatment is complete. Change and loss of vision. This is important because generally with viral and bacterial conjunctivitis, you won't have a change or a loss of vision other than through watery or purulent eye discharge. But if it's severe or an actual change in vision, those should be referred to an ophthalmologist due to the risk of what we have listed here, inclusion conjunctivitis, herpes, and keratoconjunctivitis. In terms of discharge, and this is important note, one of the ways that you can differentiate between viral and bacterial conjunctivitis, viral, you are going to have a discharge that will be watery. Bacteria, you generally have mucopurulent discharge, and that's the classic discharge that you'll see upon waking, where it's nearly sealed your eyelid shut over those eyelashes. It's that purulent discharge that's generally copious with a bacterial conjunctivitis. That's one way to tell the difference between the two. Of note, you will also see the same viral conjunctivitis symptoms with an allergen. So if it's an allergy and a viral conjunctivitis, you will see both watery discharge, but neither will have purulent discharge. It's important to understand itching as well. There can be itching with allergen, but not generally with viral or bacterial. If there's a previous infection, such as a URI, you will often see a viral conjunctivitis follow due to the nature of upper respiratory symptoms, sinuses, and inclusion of the eye. So if someone has had a recent URI and then have eye symptoms, it's usually viral. A thorough exam is warranted with any conjunctivitis. Diagnostic testing, generally bacterial conjunctivitis can be diagnosed through exam and history. However, if there is any doubt, a culture and sensitivity of the purulent exudate can be sent. Visual acuity is warranted in any presentation. As we know, viral, bacterial, allergen conjunctivitis do not cause change in vision. However, chemical or corneal injury can, and so you're essentially ruling out those differentials. If there's any question of corneal injury, a fluorescein staining or Woods lamp can be used, and you'll generally see this done in an emergency department setting. The plan for viral conjunctivitis, which is what most clients will present with, nothing can be done, and they will likely request antibiotics. So understanding the difference in terms of bacterial and viral is very important. For viral, just comfort measures are appropriate, so saline drops, warm compresses, rest, and that generally should run its course in 7 to 10 days. If it doesn't, that's a reason for follow-up, consult or refer. Bacterial, sodium sulfate antibiotic is the most appropriate, and most physicians and nurse practitioners are now recommending that we wait for 2 to 3 days for spontaneous resolution. And again, this is because of bacterial antibiotic overuse. So if it's warranted, it's generally because a spontaneous resolution has not occurred, and you can then call in an antibiotic for 5 to 7 days. A broad spectrum is appropriate, a sulfa is appropriate. Often there are side effects to sulfa antibiotics. You want to be very careful about those before calling them in for your clients. STI-associated conjunctivitis, which we talked about before, should be referred immediately, and those are for any symptoms outside of the normal viral and bacterial conjunctivitis we discussed in earlier slides. I included this algorithm, which I find very helpful, in differentials for the red eye assessment. So follow this here, take a quick peek, and this will again review the presence or absence of exudate, itching, and watery eyes, as well as photophobia and blurred vision. So take a look here if you find that helpful. This is a brief overview of otitis media, also known as OM, or that middle ear infection. These are primarily subsequent to URIs and allergies. You will find them more commonly in smokers. The effect of barotrauma is generally seen in the presence of someone scuba diving or frequently flying, as there's negative pressure in that ear canal and subsequent overgrowth of bacteria. You'll see the primary pathogens listed here. Subjective history that's important to obtain, which also includes whether or not symptoms are unilateral or bilateral and whether their hearing is affected. Okay, ruling out the differentials for OM. In the objective exam, you'll note that vital signs are normal, there's rarely a fever, and any manipulation of the tragus or the pinna of the external portion of the ear will not cause sensitivity if it's a middle ear infection. If there is sensitivity at the tragus or pinna, moving down to differentials on this slide, you'll note that that could be an external OM, also known as swimmer's ear. Mastoiditis is a very important differential to rule out with any otitis media. This is a life-threatening infection that moves from the ear to the mastoid bone. It's an infection that could be life-threatening and should be referred to a local hospital. Meningitis, you will see severe neck pain with flexion, so ensure that you're ruling out meningitis as well. Plan, follow up in 2 days. If there's no resolution of symptoms, and an OM should be completely resolved within 10 days. Acute sinusitis is extremely common. It's an infection of at least one of the 4 sinuses with the classic symptoms of mucosal drainage, inflammation, purulent discharge, and swollen mucosa of the sinuses. 1 in 7 adults will be affected by acute sinusitis, and roughly 20% of all antibiotic prescriptions are for this reason. Important to understand as a provider, as you'll be asked to write several of these within your career. Risks are listed. Most of these are subsequent to URIs. It's important to understand the difference between bacterial versus viral. One of the classic presentations is someone who tells you they've had these symptoms and it looked as if they were resolving on their own, and then suddenly became worse. And that's a classic bacterial acute sinusitis. Subjectively, your client will tell you they have intense localized face pain, and this all depends on the location of the sinus infection. Having them lean forward will increase the pressure within the sinuses and generally increase the pain, so that's one way to test for acute sinusitis. You'll note that they have copious yellow-green nasal discharge. This is very common, and oftentimes it's subsequent again to a URI. The detailed history taking is more important than the physical exam, as the physical exam is generally of limited use as long as you know the infection is within one of the sinuses. There's no way to actually test for which sinus, and there's no utility in understanding that necessarily. You would want to rule out cellulitis, and you do that upon palpation over the sinuses. If that were present, you would want to immediately refer. This pain and sinusitis can often be chronic and last for several months in clients. In terms of a plan, this is the tricky nature, as antibiotics are often helpful but not always, and because 20% of antibiotics are written for this, we want to make sure as practitioners we're not overusing antibiotics. For this reason, many physicians and nurse practitioners are recommending a 7-day period of quote-unquote watchful waiting to see if this self-resolves for most clients, and then begin antibiotics. A common antibiotic to use when writing would be amoxicillin for 7 days. Other helpful additions to treatment in the meantime are humidifiers in the bedroom and hot showers, which will increase the moisture in the mucosa and decrease pain. Nasal drops for the same reason. Warm packs over the face at the area causing localized pain, and then ensuring that your client is getting increased fluid intake and rest. I'm going to quickly review pharyngitis, which is an inflammatory condition of the pharynx. There are 3 main causes, which we'll review in these slides. They're bacterial in nature, viral. Of note, one of the most common bacterial is the group A strep. There's also Neisseria gonorrhea, viral EBV or Epstein-Barr virus. This can't be treated but should be monitored, and mononucleosis. Of note, 90% of the population has had mono by the age of 40, which means that many of us have had it and are not aware. So subjective and objective symptoms of pharyngitis. For group A strep, it's going to be a sudden onset of malaise, fatigue, high fevers over 101, a sore throat, headache, whereas mono will be more of a gradual onset of fatigue. It does become severe with peak symptoms at about 2 weeks and recovery in 6 weeks. And then gonorrheal infections are generally subsequent to new sexual partners with oral sex. Diagnostic tests. For group A strep, you can have an in-office rapid strep culture done. Most offices have this technology. For mono, you would do a mono spot test, which you may have heard of, but these do take quite a long time in labs, upwards of 5 to 12 days. Many times this is why this is not diagnosed readily. Most just believe that they have it or were told, but a monospot isn't done and it will self-resolve with rest and self-care. With gonorrhea, it's also a throat culture, which is why throat culture or a rapid strep is done if there's any question. And then plan for pharyngitis. Medication will be based on diagnostic tests. Clients with mono should avoid vigorous activity for 6 weeks, and that's due to splenic injury because you will see the spleen enlarged in the presence of a mononucleosis infection, and they should avoid alcohol as well due to that hepatotoxicity. Influenza, as you know, is a virus, and it is self-limiting in the healthy adult. We can expect symptoms to last generally a week. Those include fever, cough, sore throat, rhinitis, headache. The worst of these is generally fatigue and muscle pain, and those two can last longer than that full week because of the severity of the virus. The women at the highest risk are pregnant women. We also know that children and the elderly, all three of these in our population, are most at risk of contracting influenza and being compromised. So we as healthcare personnel should also be vaccinated, as well as educating these women to receive vaccinations. Additional contacts are those women who take care of children less than 5, or those women who take care of adults over 50, those who have a BMI over 40 or are immunocompromised. So a full list of those you should be aware of in Varney. I have listed here. The plan in general is to increase herd immunity through the vaccination to reduce the risk of contracting influenza. Once an individual contracts influenza, there is no way to eradicate the disease, but we can hope to decrease symptoms. The use of medications such as oseltamivir and zanamivir, and those can be obtained through prescription. Hopefully, if taken within the first day of symptoms, you can shorten the overall duration.